Dr. Kush Desai is our regular facilitator for this session. In the absence of him, today Dr. Odiambo and myself will be facilitating session. My name is Munirul Islam, and I am an associate professor of epidemiology and the program director of the MD MPH and MPH program at the School of Public Health, Augusta University. I am the evaluation team lead of the Georgia Colorectal Cancer Control Program. Now I know some of you already added your name, address, your clinic location, clinic name, and email on the chat. Those who have not done, please do so. This will give an opportunity for us to know better each other. And there is an example in the chat session. Brenda, help with this chat session so that they can put their information for us. First, let me review today's agenda with you, Sama. Okay, we have the agenda. So we're going to introduce ourselves, and then we'll begin with the introduction, followed by didactic presentation by Dr. Meng-Han Tsai from Georgia Prevention Institute, Augusta University. After that, we will have case presentation. Today we'll be discussing on Alaska Native Tribal Health Consortium Colorectal Cancer Control Program Partner Gathering case study presented by Lauren Smida. Today we have Drs. Santiano and Ibrahim to manage the control of this session. We'll start as we always do with a few announcements. First, we'll say about few things about Project TeleECHO, which is used for education and quality improvement purposes. All TeleECHO sessions will be recorded. By participating in these sessions, you are consenting to be recorded. We appreciate your participations. To protect patients' privacy, please do not mention any PHI in our discussions. If you have any question at the end of the presentation, please email us at au_crcscreening@augusta.edu. Data notification. Project ECHO collects many data in different forms, as you can see here. However, your individual data will be kept confidential. And we use these data for many purposes, including reports, maps, quality control, and also for to inform new initiatives. So next slide, please. So we all are now very familiar with the Zoom rules. During the didactic presentation, please keep yourself muted. If you can, if you need to ask a questions, and you can do so either by typing or by raising electronic hand on the very lower right corner of the screen. Also, you can, use the chat session at any time. And we would like to have your camera on. However, if there is a bandwidth issues or other concern, that is okay with us. Please introduce yourself with your name and clinic whenever you ask a question or speak. Also, if you have any technical issues, you can type that directly to Brenda in the chat session. And does anyone have any question, concern about this session? Please let us know. Now, I'm going to be introducing, and I'm very happy to introduce Dr. Meng-Han Tsai, who is an assistant professor of cancer epidemiology at the Georgia Prevention Institute with membership of Georgia Cancer Center at Augusta University. Dr. Tsai's research interests are colorectal cancer prevention, outcomes, and survivorship. She has conducted several studies on colorectal cancer screening utilization and outcomes among high-risk adult populations and underserved and vulnerable populations. Since 2022, she has published several studies that examine guideline concordant colorectal cancer screening utilizations among cancer survivors. She also has published several papers on the time trend of colorectal cancer incidence and mortality, and also predictor of colorectal cancer outcome in Georgia. Welcome, Dr. Tsai. Take it away from here. Thank you.
Okay, thank you so much for the introductions. So today I will talk about one of my project is to study the county level colorectal cancer screening rate on the colorectal cancer survival in the state of Georgia. And then we will consider the rurality matter. So next. So just give a little bit background information in the Georgia. As we know, like colorectal cancer is the one of the most common cancer deaths among men and women in Georgia. So with about 40.1 estimated deaths per 100,000 population, and this mortality rate actually is higher than the rate in the United States in 2020. And as we know, like the screening usually is a very preventable methodology, can reduce the mortality for the patients or residents. However, in Georgia, the screening rate still fall behind the national goal. Even we see some of the literature showing the CRC screening rate increased during 1997 to 2018 by about 48 to 71%. And just important to know this prior literature, they used the national survey, and most of the time those participants, they have insurance. So that's why you can easy to see in the 2018, their screening rate can go up to the 71%. And the next step is like, as we know, the CRC screening is very important, but the thing is, what are the barriers contribute to the accessibility of cancer screening? A lot of time may be due to the limited screening facilities or maybe lack of transportation. So those factors are linked to the place the patients or residents they live. So a lot of times when the county they designate as a rural area, commonly face several challenges, including like systematic investment and also hospital closure. So those may gradually impact the rural residents' overall health. So not just limited to the colorectal cancer. Next. So because those literature showing some of the gap, the first gap is we can find is most of the study, they did not really consider the inferentials of CRC screening rate at the individual level data. So either most of the literature, they focus on the patient level data, or either is more like we call ecological study design. So which means they focus more on the geographic level data. So none of them, they consider like using multi-level data to really see how does the area level factor impact the individual level outcome. And the second part is limit study have really looked at the impact of rurality on the CRC outcome within a small area. So when the study focus on the small area is always important because it can easy to inform the local public health initiatives. Maybe we can see is it need the intervention or some of the navigation can help to improve some of the cancer outcome. So with that being said, so our study purpose is want to look at the 5-year CRC survival rate according to the county level CRC screening rate. And we also stratify by the county level rurality. And further, we examine the associations between the screening rate and rurality and the 5-year CRC survival in Georgia. Next. So right now I will talk about some of the methodology I use for this study. So this is retrospective cohort study. So I use several data to link together. So including the county level data and also the individual level data. So all the data sources are publicly available. So for the county level data, because I need to know where the patients they locate, the place they live is considered the rural or considered urban. So I used the 2013 United States Department of Agriculture Rural Urban code to identify where those patients come from. And then for the screening rate, I gathered the NCI, the small area estimates for the screening behavior. So using data from 2004 to 2010. This is the most recent one I can find. And then I link to their individual level data. So I use the cancer registry. So this we call SEER. And because the data year need to be consistent with screening data year, so I only use the cancer registry data from 2004 to 2010. Next. So there are a few factors we are interested in this study. The first one is outcome. So our outcome is definitely the colorectal cancer survival. And there are two independent variables we are interested. The first one is county level CRC screening rate. So as I mentioned before, I use the NCI small area estimate to gather the CRC screening use. So their data, they report the screening rate in between 2004, 2007, and also 2008 to 2010. I use those informations to link with their county code and then together like based on the patient's location. But how does NCI they define the CRC screening? So they consider if the individual they are 50 years or older, at least have one colorectal endoscopy, so like sigmoid or colonoscopy in their life, and or either they have at least one FOBT within the past 2 years by the time of interview. So they use those definitions to calculate the screening rate by each county in Georgia. So once we link with this information to the patient level data, we further to classify as the screening rate as a 3 levels variable, so like low, intermediate, and the high. So we use the 5 quartile. So this cutoff point is kind of based on the NCI small area estimate to so if the county, their screening rate is 45.4% or lower, we will define as low. And if their county screening rate is 60.8 or higher, we consider as high. So middle 3 quartiles, we consider intermediate. Next. And the next independence variable we are interested, we call is the county level rurality. So what I mentioned earlier, so if patient, their code is in between 1 to 3, we'll consider they are not in the rural area. But if their county with the code is 4 to 9, we'll consider rural area. And the next step is we still take consideration for some of the covariance from the cancer registry. So those are in the individual level data. So including like demographics, characteristics like age at diagnosis, their gender, their marital status, and also their the Georgia regions. And we also further include the tumor feature like tumor grade, stage at diagnosis, and their primary location. Next. So for the analysis plan, we use the descriptive statistics to describe the CRC screening rate and also the rarity, demographic factor, and definitely the tumor characteristics. So this one, because it's a survival, want to see the colorectal cancer survival. So we use a survival analysis at the 5-year interval and using Kaplan-Meier approach. And further, we use the cost proportion hazard regression model to examine the impact of county level CRC screening rate on the CRC survival among Georgia. And then we further consider the moderating effect of rurality on this association. Next. So right now we will start to talk a little bit about the results I find from this study. So at the beginning, just want to give a little bit background about what are the final samples being included for the data analysis. So we include adult age 50 or older because based on the NCI, their small area estimate, their screening criteria. And finally, we include about 22,160 patients in this study. And when we look at their distributions in between like demographic and cross the 3-level CRC screening rate area, we can see the age and the gender did not show very strong, like significant difference across this 3-level screening area. However, we can see the race showing some of the difference. In particular, like for the Black population, if about 38% of Black patients, they live in the CRC screening, consider low CRC screening area. But majorities of white patients living in the intermediate and the high screening area. And further, when we look at the marital status, a lot of time marital status is also the important factor can link with like social support. So that's why we also report this outcome. So we can find if patients are single, they usually live in the low CRC screening area. But if they are married, most of them they're living in the intermediate and the high CRC screening area. And we further classify the Georgia region, and we find most of the patients, if from the central regions, they are living in the low CRC screening area. So next. So the second table just will give you more clear idea about what the key study purpose we want to see. So if we because the rarity and also county level CRC screening rate area is kind of our two factors of interest. So when we look at this cross-tab table, we can see if patients that live in the rural area, there are about 33% of them living in the low CRC screening area. But if they are not living in the rural area, it's about 87 or 88% of them living in the high CRC screening area. So next. And further, we use the multivariable model to really look at when we adjust the different covariance, how does the two factors interest are still showing the significant difference? And when we look at the model 3, when we adjust all the factors, including like demographic characteristics and also the tumor characteristics, we can see if patients that live in the intermediate and the high CRC screening area is about 8 to 9% reduced risk of CRC death. And if some of the patients that live in the rural area, you are about 8% increased risk of CRC death. So next. And then we further to take considerations about how about the rurality. Does rurality also play the role affect the associations between the county level CRC screening rate and the risk of CRC death? So the finding we find is like if patients live in the non-rural area, you can see the red color. And if they are living in the non-rural area and also living in the CRC screening area is considered intermediate, and the high is also about like 9 to 10% reduced risk of CRC death. However, we did not see the very strong outcome among those living in the rural area and stratified by the level of CRC screening area. But the last part is more importantly, you can see from, I'm not sure if everybody can see, and my curse. Okay, so if patients live in the high screening area, actually rurality seems more play the important role because you can see if compared to those living in the urban area, if patient living in the rural area, actually is about 18% increased risk of CRC death, particularly for those living in the high CRC screening area. So that might be something you can discuss further. So next. So further, we use the Kaplan-Meier curve to really show their survival rate. So the first figure is kind of give you the broad view about the CRC survival rate across the 3 level of screening area. So it's not surprising if the patient they live in the low CRC screening area, their 5-year survival rate is considered lower compared to those other live in the intermediate and the high screening area. So next. And then we further to stratify to see the different level of CRC screening area and by rurality to see that showing difference. But however, we did not see the outcome is showing significant difference when the patient they live in the low and the intermediate CRC screening area. However, the high CRC screening area show a very significant difference if they are living in the rural area. Can see this blue line. Their 5-year survival rate actually is lower than those did not live in the rural area. So for the rural patient, it's about 68%, but non-rural patient is about 72%. Next. So based on those findings, we can summarize what are our key findings. So we can see the patient living in the low CRC screening rate county have a lower 5-year survival rate. And in particular, the 5-year survival rate also showing significant lower when patients live in rural area and also the high screening area. However, we find if the patient live in the urban area and also in the intermediate and the high screening area, while about 8 to 9% less likely to die from the colorectal cancer. Next. Even we find some of the important information, but there are some limitations that I think still need to be mentioned here. So the first thing is our outcome may be underestimate or overestimate how county level CRC screening rate impact on the survival outcome in Georgia. Because we are unable to know the county residents were those patients who had the CRC screening while the same individual diagnosis with were dying from the colorectal cancer. And also, we don't know if there are same participants, they maybe have a multiple screening use. Because the NCI, when they calculate the CRC screening rate, they use the national survey. Those national survey are cross-sectional design. So which means they did not follow up the same individual across different time. So that might be some of our limitation. And the second, we use the county level CRC screening rate to really look at the colorectal cancer outcome may not fully reflect the actual healthcare resources. Some of the other factors may also need to take consideration. Does the limit treatment option may play an important role in diagnosis outcome for the CRC patient in Georgia. And the last part, this is a lot of times more linked with the patient living in the rural area. Does the systematic barrier to the cancer screening for the CRC was not available for our study also. For example, some of the factors we find those are also important, like, for example, the ability of CRC screening option and also like follow-up care. And also, does the patient have a difficulty for scheduling their screening? And definitely the preparation instruction, does that really also impact the screening uptake? So those factors should also need to be taken consideration with the colorectal cancer outcome. So next. So based on our finding, there are a few implications maybe for either future study or for in the clinical practice. And because we know people live in the, or patients live in the low CRC screening area and also rural area usually have a more likely to die due to the colorectal cancer. So some of the intervention maybe need to consider to improve like accessibility, timeliness, and also quality of CRC treatment. and also the ability of CRC screening option. And the patient navigations has been showing like it's very useful to make sure the patients, they can have access to care and also the CRC screening. So that's also another thing should be considered. And when we talk about the, particularly in the rural area, transportation is another barrier. So that might be something also need to consider. And the last part is we really need some of the data can gather more multi-level factor, especially at the area level factors like healthcare resources within the small area to really help us to study or investigate how does those in the area level factor can associate with the cancer outcome in Georgia, because they can give us more clear idea like how to promote some of the public health initiatives within the small area. So next. So this study, the study I just present, this is already been published this year in the Cancer Medicine. So if you are interested to look at more detail, and just have to share another information. We have another study. We investigate the role of CRC screening rate at the county level on stage at diagnosis only in rural Georgia. So this study also have been published lately in the Cancer Causes and Control. So if everybody is interested, also can look further. And because today we did not have a lot of time, we'll talk further about this, what we find from this study. So I just put the key finding here. So in this extended study, we find that if patients live in the high screening area, we're more likely to have a later stage of CRC in rural Georgia. So we really need to look at like, does most of the patients in this area, what is their CRC screening history, or have they ever done any CRC screening before? So those information is what I want to share today. So I will take the questions.
Well, thank you, Dr. Tsai, for your wonderful information enriched on colorectal cancer screening and survival in rural areas. So we have some time to questions. Anyone has any questions, you can type your question or you can raise your hand so that we can get answered from Dr. Tsai. Well, I do have a question. Oh, there is a question. Miss Diana Redwood, go ahead, please.
Yeah, I had a question. I don't know if you can go back to your conclusion slide. I was surprised when you said that rural areas with high screening rates had lower survival. Oh yeah, one forward. And that surprised me. So can you talk a little bit more about why high screening would be just because you're in a rural area? What the impact between that do you think the rurality is somehow affecting future, like the cancer treatment, or can you talk about that?
Sure. Yeah, but for this part, we definitely need more data to support. But so far, based on our finding, the one of the reasons we can thinking about a lot of time in the rural area, either limited resources or either patient did not aware about like CRC screening. So probably when they come to their physicians, they already diagnosed with colorectal cancer. And even some of them probably already is more like advanced diagnosis. So that's why earlier I mentioned like we really have to look at, or maybe go back to see what are the CRC screening history for each patient, because you cannot just done one and then, yeah. So it's supposed to have a like regular screening, or either some of them, if they find some of like polyadenoma, does they follow up the screening at a different time. I hope I answer your questions. Yeah.
Thank you. Any questions on the chat session?
I have a question.
Go ahead, please.
I see that Dr. Hart's also
Dr. Hart,
like me.
go ahead. Dr. Hart will be second.
So you mentioned that you used the 2004 to 2010
Mhm.
screening rates from NCI. Did you consider the CDC that have a little bit more updated screening rates? It's also small area estimates, and they take into consideration, I believe from 2020, all the different, there are 5 different measures for screening, including all the fit tests and all the, and the others. So did you consider using that? And I wonder, especially since, colonoscopy is
Yes.
the gold standard, but we have others as
Yeah.
well, how that would impact, right?
Yes.
The results.
Yeah, I think this is also the challenges when I try to look for the data source. And a lot of publicly available data, they did not go to the very small area. So if like what the data you mentioned, I definitely interested, but just so far I'm not sure is it who I should contact to get those
So I can,
yeah.
one, I can definitely help you.
Okay. Yes.
I'm not CDC, but I
Okay.
use that data a lot. And
Yes.
very easy to
Okay.
so yeah, you're welcome to contact me and I'll help you with that.
Okay. No problem. I appreciate that. Yeah.
Of course.
Dr. Haas, please.
Yeah, thank you. Very interesting presentation. The National Cancer Institute identifies rural as a separate risk factor for poor outcomes. And they recognize anybody in a rural area has challenges.
Yeah.
And part of that is even if you're high screening, negotiating the complex system of care. Harold Freeman found out even in Manhattan, when they started doing breast cancer screening in Black women, unless they attached a navigator, they still got worse outcomes. And I think that's one of the centerpieces of the CDC project that we're trying to do, is to say we recognize the fact we've got all of our CDC projects now are in rural Georgia, and we're putting navigation on top of that to try to make certain that when we do get testing, that the time to definitive, like colonoscopy after a stool-based test, is as short as possible. Because, that was Harold Freeman showed that with breast cancer. The quicker you got to treatment, the better the outcomes, the lower the stage and all that. So I think, this data kind of reinforces the placement of our CDC program, the emphasis of developing a strong navigation system, but it does bring up the challenge of, who pays for navigation,
Yes.
especially in uninsured people, and, how can we look at the efficiency of navigation? And we've taken some looks at that, but I think this is just another indication that what we've got to do is think about rural as a risk factor, and something that programmatically we try to overcome. Thanks again for the presentation.
Well, thank you. If there is no other questions, we need to move on for our next session, which is case presentation we have today, and is from Alaska Native Tribal Health Consortium Colorectal Cancer Control Program Partner Gathering Case Study, and which will be presented today by Lauren Smida. Welcome, Ms. Smida. Take it away.
Thank you for having me today. So before I get started, I just wanted to, you can go to the next slide. Sorry, I'm going to get used to do that. I want to give a land acknowledgement. We acknowledge the Dena'ina people on whose traditional lands we gather. We also acknowledge all Indigenous people of Alaska and thank them for their past and present stewardship of the waters, plants, animals, and spiritual practices of this place. So next slide. So just to give you all a just general reference of the size of Alaska compared to the rest of the United States, here is an overlay. And you can see that Alaska is quite large, and all those red lines are referral lines, and that where all the lines meet down in the bottom there is Anchorage, where I currently reside. So not a lot of our regions most of our regions all have to fly into Anchorage to get screening and medical care. Some of our regions do have the option for colonoscopy. However, if their patients are high risk, they still have to fly to Anchorage. And just for a little reference, most of the places to fly from wherever you're flying from it, rural Alaska to Anchorage is at least an hour typically or more. So you can go to the next slide. So we were funded, the Alaska Native Tribal Health Consortium was funded by CDC in the Colorectal Cancer Control Program in 2020, and it will be ending in 2025. This started during the pandemic, not the greatest time to increase screening. The focus of our program is with our tribal health organization partners and creating sustainable improvements in screening. And I want to highlight that the reason why screening in Alaska is because Alaska Native people face a challenge and burden of one of the world's, if not the world's highest rate of colorectal cancer. Alaska Native people not only have 2 times the incidence, but they also have 2 times the mortality. And the incidence and mortality rates are not declining as they are in other populations. So that is significant. So move on to the next slide, please. So who are our partners? As you can see here, we are heavy on the western part of Alaska. Our partners range all up and down the coast there. And that star is Anchorage, where we are. All of our partners had to fly into Anchorage to come to our in-person 2-day meeting. And you can see up there in the corner, there's a small plane, people loading their stuff onto that plane. That is a typical transport to get around in most of Alaska. There are no roads. Next slide. So here is our wonderful group of all of our partners who came for 2 days in Anchorage. And this is a nice photo of them. So our first day, you can go to the next slide. Even though everyone lives in Alaska, as I mentioned, we are very far spread apart from each other. And even though we're all working on the same program and trying to increase screening, we don't know each other necessarily. So we had an icebreaker, find the person that has whatever is in the little box for your bingo game. And this just encouraged them to talk to each other, get to know each other, and fill out their bingo game. So that's just a picture of them doing that. You can move on to the next. And so the first part of our meeting is Diana Redwood and I gave we gave updates on what we have been doing here at the Alaska Native Tribal Health Consortium, of our successes and challenges. We did a number of site visits around the state this year. We did a number of provider presentations during our site visits, as well as on Zoom and education events. We did a local radio PSA announcement. Radio is still very commonly used and listened to in rural Alaska. So that was a good way to get CRC screening message out. We've had a few publications, and then we also flew out to a couple of our partner sites to help with setting up a Fit Kit send out program and helping them with the process of getting Fit Kits set up. Next slide. Most importantly, and this took up a majority of the first day of our meeting, is our partners sharing their updates, their successes, their challenges, and many of them have the same challenges, and the differences is that they deal with them differently. And so it was very important for them to share. A lot of conversation and learning happened. I learned, as well as all of our partners. They all have issues, barriers with travel, obviously. Staffing is an issue. And this was essential to them getting to know each other and also communicating of how to address those challenges in Alaska. And now they're all connected. Next slide. The second part of the day, we did some process mapping. We always encourage our our partners to implement stool testing. Most of them do use stool testing, but like I said, they have lack of staff, so sometimes it's difficult to do big send outs or to make sure you're following up every year for stool testing. So we did process mapping. Each partner had their own map, and then afterwards we went around and talked about each other's map, talks about the gaps, and maybe how some of the solutions to those gaps that we could address, and learning from each other and how each of the organizations do it differently. Next slide. So even with the challenges of low staff, barriers, and COVID-19, we have increased our screening in the last 3 years. This is just all of our partners together. That's their percentages. It's not individualizing anyone. And we hope to continue to increase screening through these efforts and in turn reduce CRC incidence and mortality. Next slide. And here we have some of our small media stuff that we've done recently. As you can see, it's very heavy on puns around Alaskan animals. I think a notable thing that we were able to do is, if you see here on the left lower corner, we were able to translate our media into Yupik, which is the most common indigenous language spoken in Western Alaska, which is where most of our partners are. So that was a great success. And then next slide. So I just want to say thank you. And if anyone has any questions, I'd be happy to try to answer them.
Well, thank you for your wonderful, precise presentations. Now we're going to open up for discussion. We have pretty good time, so I welcome everyone to, to participate. This is one of the things that we like to do, more engagement, learn from each other. So what worked in Alaska, see whether we can replicate somewhere else. So I start. Oh, there is a question from Dr. Rodiambo. Go ahead, please.
Hi, Lauren. Thank you for the presentation. So I'm just curious. You said that sometimes people have to fly into Anchorage to get the screening done. So here we have the gas cards that we give in order, structural barriers to overcome that. So we give them gas cards, so that is hopefully addressed. So how does it work with the flight? Is there any support in terms for the transportation to come for the screening, or is that something that the individual has to bear?
If they are Alaska Native, there's a lot of times the tribal health organization that they are part of will help pay for travel. And then Medicare, I think, also helps pay for travel as well, depending. But some rural patients, so we have what we call hubs. So the largest community in a region. So a lot of patients still have to fly from their small community to the hub, and then sometimes from the hub to Anchorage. So it does, many times it gets paid for, but I can't speak for all of the tribal health organizations, but most of the time it is covered. The issue is time as well, and a lot of people don't want to leave their home and their kids or whatever is going on in life, because they end up having to stay in Anchorage, 4 days to complete a colonoscopy at least.
Wow, okay. Thank you.
Yep, thank you.
Thank you so much. Well, I do have a question for the so different organization pays for their transportation. How about when it comes to the treatment? It also paid by insurance, some form of, or is paid by patients, or what's the arrangement? Those who do not have the ability to pay.
So we are part of ANTHC is tribally owned and managed and operated by a consortium of about 200 Alaska Native tribes who compact with the federal government. So most of our patients are part of the IHS system. So that does help with payment of any, like if they get cancer or colonoscopies. Each organization within is a little bit different within our within ANTHC's consortium. Each organization can be a little different on how they do things. but most of our patients are IHS. So, does that answer your question?
Yeah, that's okay. Now, Dr. Hawes, you have a question. Go ahead, please.
Yes, I just wanted to know what the completion of colonoscopy rates are after positive stool test, and how long does the period usually take to, what's the average period to get it completed?
That is a good question, and that varies a lot depending on the area. I will have to say that some of our areas, that until recently, stool tests were, you know, if you had a positive, insurance wouldn't cover the follow-up colonoscopy. So I think sometimes our organizations were hesitant at first for doing that. You know, even though IHS will help pay for colonoscopies. It depends. Honestly, patient navigation and having a patient navigator do all of the follow-up is pretty much the most important thing for any of our patients to get care, to get follow-up on their colonoscopy, to get follow-up on a positive fit. We were just visiting Kodiak this last week, and that is probably the most important part. The provider following up with the patient, and then patient navigation. And I can't say, it really depends on the different areas and whether or not they have a patient navigator or not, to be honest.
Well, I will point out the fact that you're nearing 60% for your screening rate, and having done this 20 years, 60 is extremely good accomplishment, especially when you consider, we talked about rural Georgia, and it looks like, you know, rural Georgia is just a tiny drop in the ocean compared to what you have to navigate there. So I think it's a significant accomplishment, but it really talks to the point about some of these rural barriers and other things can be overcome by, you know, a well thought out system of cooperation, like you guys are showing. So I think it's a real tribute about what can happen when you get your act together and develop a system to try to attack these challenging issues. So to be congratulated for that.
Wonderful.
I should point out that community health centers nationally are sitting at 40%. So you're 20% above what the average community health center does in this country.
We work pretty hard. We also have a smaller population, just a much larger area to get people to the colonoscopy, but yes.
I think that's Lorian, do you have a question?
Yes, I just had a quick question. And speaking of systems, right? You talked about your partners, each of them created like a process map for them to follow. So in terms of evaluation, the process really matters, right? How they do it. So do you think everyone is like, what are you doing to make sure people are following all the steps? Is there a way you're evaluating that to know like where the gaps are and how to improve?
We currently have not done an evaluation. We pretty much have just kind of started with this process mapping. We are following up actually in June with them in a meeting to talk about it more, to see how things are going. Each organization, like I said, does things differently. So they have each one of them has a little bit different of a process. Some like to do big mail outs, you know, happy birthday, you're 40, here's a fit kit. And then some just like to give it out to patients who are due that are, you know, lower risk. So they all do it a little differently. They all enter the information and orders and discerner differently. So it's kind of trying to follow up with each one of them and encouraging them to use fits more as well, because that is part of it. But we are following up with them, but we just started this in April. We did the fit process. So we will be continuing that and following up to see how they're doing and evaluating to see how it's going.
Yeah, that would be very informative. Thank you.
That is wonderful discussion. I think the big, you know, you mentioned one point that you deal with a smaller defined population with a big land mass area. So once you can set up a system and collaborations, is then it works better. But Dr. House mentioned about rural Georgia, even though it's a small area, but a lot of people and a lot of different mindset. And we were working hard to set up system so that we can bring in most population under the screening program. But as Dr. House mentioned that Alaska, your rate is much better than the federally qualified health centers average rate in the country. Wonderful job. Thank you. Kudos.
Thank you.
Any other questions from anyone else?
There's a question in the chat.
Okay. Yeah, there is a question. What have you found were the best strategy processes that might improve screening rate? What advice would you give us to live in lower 48? This is from Martin Sheldon, Dr. Sheldon.
My personal experience working on the colorectal cancer control program, I would say, is connect with a clinical person who is passionate about screening colorectal cancer to some degree, and then also have a patient navigator. I can't stress enough how much they make a huge difference in screening rates, and just finding that one person that's willing to get things moving, increase processes, that has connection within the organization, that's able to go to, the doctors and stuff and talk to them to help improve their screening. But I will say that at least with our patients, they might know they're due for a colonoscopy, but they won't go get one until someone calls them and lets them know that they should come in and get a colonoscopy. So I've been told that number of times from our partners. So having someone call, especially for our elders, is, yeah, definitely that's the most important part of getting people in and screened. And then since a lot of people come into Anchorage for screening, having a patient navigator here in Anchorage that connects with all of the rest of the organizations around the state that can help people refer their patients to the main hospital here in Anchorage they recently started a few years ago, and it's made a world of difference. So patient navigation, I would say.
Wonderful. Thank you so much.
Thank you.
Thank you, everyone. Thank you, Dr. Tsai, and you for your presentation. Is wonderful learning for all of us. So I'm going to be summarizing take-home message from both presentations. And I would like to take it very simple and easy so that we all can remember. Number one, patients living in low colorectal cancer screening rate area had lower 5-year survival rate. Even though the rurality has a big impact on that, from the didactic presentation, we learned that. So if we can think about that, if you screening, then there is a better chance. But it's still, if you live rural areas, the survival is lower. So we'll have to work on these many different facets of quality of care, diagnosis on time. Time is as essence, as many presenter and comments came today. Time is an essence when we have dealing with cancer, especially not only colorectal cancer, many other cancers. So quickly identify earliest stage, have a proper diagnostic and treatment, and also follow up. So all do these things so that we need to keep our hope and activity action. And we learned second today a very simple learning that we can do it by we can increase the colorectal cancer screening. We can bringing them under the navigation, which has the big impact on the patient screening, increasing colorectal cancer screening rate. And once we screening, then everything falls. From the case presentation from Alaska Native, they showed consistently over the year how they have increased their colorectal cancer screening by placing different intervention in the system process. So kudos to all of you today that there are only two simple ways, because I want to keep it simple. Increase screening and also a system in the process so that we can deal with the cancer. Now I'm gonna request Dr. Odiombo to take us to the closing step of this session today.
That's it. Thank you so much, Dr. Islam. Okay, so as always, we have our CME, CNE at no cost. If you look in the chat, they'll be posting a link and also an activity code that will allow you to access the credits. Also, the good thing is that this information will also be sent out tomorrow morning or sometime tomorrow. So if you're not able to capture it today, please be on the lookout for the email tomorrow. And we just want to thank your presenters, Dr. Tsai, and of course, Lawrence Smider. Thank you for your insight, your experiences. I think they're very informative. And as always, for attendees, we are always happy to see you. And in that sense, also, we have our next scheduled ECHO session, August 7th at 4 p.m. And that will be our 22nd ECHO session. So we look forward to seeing you. And as always, we're looking for presenters. So thinking about the case presentation, didactic presentation. If you would like to present, please feel free to contact us. And if you know anyone who would be a good fit to present and to give us some insight in the CRC field, you're more than welcome to let us know too as well. So thank you very much. And we hope you have a great rest of your week. And please feel free to log off whenever you're ready. Thank you.